So I think as we have seen in the transposition dinner plate, we may have several options. We have the partial tendon VRT, the full tendon VRT, single muscle superior rectus transposition or IRT, augmentation by resection, augmentation by Foster sutures on these muscles, augmentation by cross section, and then we also have the plus effect by antagonist MR recessions, by MR Botox in the opposite muscle, and then agonist LR plication. So these are the different options which are available, and of course the desert with Nishida with modifications is there. So these you have seen some cases shown by Dr. Ankur very nicely. I think we will move on. The Nishidas, as we all know, is a procedure which is no disinsertion, no splitting, so no risk of ASI. Just like the plication, it's a good procedure which we have to our armamentarium. Direct vectorized force to the sclera by non-absorbable sutures, and there is no lax middleman like in Jensen's. So Jensen is something which I have never liked, because it may work for some time. Gradually, the force you are transmitting is through the lax middleman, that is a lateral rectus, which is itself paralytic. It gives way. So gradually, whatever force is there, it will be lost. These are vessel sparing procedures. So now we talk on the third nerve palsies. In third nerve palsies, which is one of the more complex problems that we have, we may have different challenges in different forms. As you all know, it involves almost all the muscles on the one side except the lateral rectus and the superior oblique. So you may have a full picture, full blown picture with an exotropic eye, which may be 85-90 prisms, neither elevates nor depresses, and of course there may be the pupillary and the involvement of accommodation. So I think for the PGs particularly, never forget that part, that it may involve. The ischemic neuropathies are there which have to be kept in mind, which may be sparing the pupils, not in all but 70%. And then there may be aberrant regenerations which have to be dealt with separately, and you may have associated neurological deficits in many of these people. Now this individual, old individual, had an ischemic mononeuropathy. Why? Because if you look at his pupils, you will find that they are having the same size. There is no anisocoria. So never forget to look. Whenever you have a third nerve palsy, a person is coming with ptosis, exotropia, neither elevates nor depresses, look into the pupil. If the pupils are no anisocoria and the accommodation may be good, of course in this individual accommodation is lost because of presbyopia. So if this is there, then we have to deal with differently. So in these cases, a complete motor diagnosis is made. Since we are suspecting an ischemic or a vascular lesion, we should rule out hypertension, diabetes mellitus, CAD or CVA. So monitor these things. ESR, CRP also should be seen. Thesis done by Dr. Priyanka, we saw that the 60 cases of ischemic mononeuropathies, 25 of the 60 had diabetes mellitus underlying, hypertension in 15, hypercholesterolemia in 8, hyperlipidemia in 20 others. That means triglycerides were raised. So these may sometimes, if you find after a week that there will be an involvement of pupil or there is a worsening, then don't forget to do an imaging. So you may wait for 3 to 5 days when we are seeing these cases which are pupil sparing, but call the patient back and do imaging if required. Management in third nerve palsies, after you have ruled out the causes and then you are kept on follow up, minimum we wait for 6 to 9 months if there is no other thing to be done. And crutch glasses are used for ptosis. Surgery, how we'll do, we'll talk about. Now this case is an example. He is himself a doctor, and what we saw was an exotropia, and in such a situation when the eye is coming up to the midline, I prefer to do a recession and a plication procedure. So you see here LR recession of 24 millimeters was done. So it's a supramaximal recession because we want that lateral rectus to be easily relaxed. And the MR plication of 8 millimeters was done, and you have these post-op pictures, and he is very happy. He is going back to work. If you have a lateral rectus which is tight but not fully tight, LR is not very tight, and there is no crossing the midline, then you have a choice of doing a split lateral rectus transposed to the medial side. So this is a very good procedure which has come to our hands, and we have used it in third nerve palsies with very successful results. And there are several people, and there are a good amount of people now doing even in India. And you will see that there is a combined multi-center study which was published under Linda Daghi. Now case 3, this is again having large exotropia, but here the verticals are quite a bit, and the lady wanted the exotropia along with that vertical also to be corrected. So what we can do in such situation is contralateral superrectus recession. If you do, it also takes care of the ptosis to some extent. The pseudotosis element which is there will be improved, and so the hypotropia gets corrected, the pseudotosis improves. So in such a situation, LR Y split to the medial rectus side along with the contralateral superrectus recession was done. Now this case is having a tight lateral rectus. So if you have a tight lateral rectus, Y split LR to the medial transposition is not recommended. In such a situation, you have to do a supramaximal recession or a periosteal anchoring of the lateral rectus. So the lateral rectus is anchored to the periosteum on the lateral side, and then you can tighten the medial rectus if possible, or if the medial rectus is totally not allowing that, then you have to anchor the globe also to the medial side. So you have anchored the lateral rectus on the lateral periosteum and the globe to the medial periosteum. So this is another case in which very tight lateral rectus was there and 90 prisms, and you can see that how this has been done. Earlier we had recommended using the DCR skin approach, but now we usually do the precurricular approach. Aberrant regeneration, if there is, then it has a different ball game. Now this individual has a third nerve palsy, but what you see that the lid gets elevated here on this abduction and also in looking down. So this is a pseudo von Graffe sign. So but the interesting part is the exotropia gets corrected. It's not much. So in such a situation, we may not do any surgery, just counsel the patient, and if he is interested for the ptosis thing, we have to explain to him. Now if you have an exotropia which is substantial along with aberrant regeneration, you may choose to operate on the contralateral horizontal recti. Now here the counseling is very important. You have to explain to the person, and usually you will have to show them that what happens. You can take a picture of the person with the contralateral eye fixed in the other side and see what is happening, and then show them that look, the ptosis will get corrected by your surgery being done on the contralateral eye. And this is what was done in this case, and you see here how the exotropia is corrected in the other eye, which corrects the ptosis in the left eye. So the aberrant regeneration can be handled differently. Now this case 7 shows you another type of third nerve involvement in which the inferior division alone is involved. There is no ptosis, there is no superrectus involvement. So inferior division is involved, inferior rectus is involved, and exotropia, the medial rectus, is also involved. So in such a situation, you have to handle it little differently. So what we did was an FDT was done to see the lateral rectus and superrectus were free, not very tight. So modified inverse NAP procedure. So what we have done, the modification NAP for the inverse means for the inferior rectus, lateral rectus has been reinserted without any recession, and the medial rectus was resected 6 millimeters and then inserted at the RIR. So we have done a combination of NAPs and a horizontal resection procedure to take both into account. The exotropia gets corrected, and you see here the exotropia is corrected as well as the abduction has improved substantially. Another case shows you another problem, and this is a right residual third nerve palsy with lateral incomitance. Now here earlier surgery was done, a right retractus recession has been done elsewhere 12 millimeters with a plication of 6 millimeters, but still she has an incomitance. Now you see these deviations, 8 prisms here, 16 in the primary position, 35 prisms in this gaze. Now there is a large, whatever you do, you may not be able to correct both. So what should be done? Scott procedure. Now that is something which you can do on the lateral rectus, and that is what we have done. A Scott procedure on the left lateral rectus, 6 millimeter resection and 12 millimeter of recession on the lateral rectus was done, and now you see the post-op, she's got corrected the abduction, and these are okay. The last case is showing you twice operated elsewhere in Kolkata, and the patient came to me. So what I did was explored it. It's a re surgery. So lateral rectus recessed 25 millimeters, 7 millimeter hangback, and an inferior rectus belly transfer. Now half Nishida, a good name has been given, belly transfer surgery, because we are just shifting the belly of the inferior rectus to the side. So it's a belly transfer surgery to the medial rectus. So this was half Nishida which has been done. So important points to remember in third nerve palsy: you look for the deviations in primary position and other gazes. Fixing eye, find out, because you have to deal with which is the target deviation will be determined by the fixing eye. Look for the incomitance. Look for the realistic goals to be set and counsel the patient. Nothing can be corrected fully in third nerve palsies. Individualize the treatment. FDT for the lateral rectus is done. That will decide the surgery. Supramaximal recessions may have to be done. Periosteal fixations may be done. And sometimes we can do a split lateral rectus to the medial rectus side. And option of contralateral muscle surgery is also there. So third nerve palsy is a real gamut of procedure. We have to be a squintellectual to handle it. And we are all squintellectuals here. So this is how a third nerve palsy can be after surgery. And